Good evening, everyone. My topic for today is pre-anesthetic evaluation in oncology, key concerns and considerations. So I'll be discussing the topic under these headings. Majority of challenges anticipated by an anesthesiologist are encountered in oncoanesthesia, right from difficulty in securing an IV line to securing a difficult airway, management of major fluid shifts, and blood transfusion. So what are the challenges that we face in cancer patients? It could be because of cancer itself causing cancer, cachexia and malnourishment, effects of chemotherapy, immunotherapy, and radiotherapy on systems, systemic and local effects of disease itself, and cancer-related pain and associated medications. Perioperative management of cancer patient can be challenging. So what makes them different? Direct and indirect systemic effects of cancer and side effects of chemotherapy. Timing and purpose of cancer surgery varies. It could be either diagnostic, therapeutic, or palliative. Cancer surgeries are neither elective nor emergency. Time available to optimize the medical condition of patient is limited. Preoperative medical evaluation should include nutritional status, functional status, and general medical issues assessment with thorough history of chemotherapy or radiotherapy, symptomatic control, and prehabilitation. Multimodal prehabilitation. It's a preoperative program that combines various interventions. Why is it important? To improve patients' functional status before surgery, after neoadjuvant chemotherapy, and enhance postoperative recovery. Multimodal prehabilitation includes exercise, nutrition support, psychological support, and optimization of medical comorbidities. Nutrition. Cancer and chemotherapy induces nutritional deficiency because of malabsorption, and there could be increased metabolic demands and low albumin levels. Why nutrition is important? It's an independent predictor of postoperative morbidity. Surgical site infection, delayed wound healing, and recovery are some of the consequences, along with impaired muscular and respiratory function and prolonged hospital stay. These are the various articles that tells us that perioperative nutrition support will definitely help to reduce the severity of postoperative complications, and patient will have a better postoperative outcome. How do we assess nutrition? One is by MUST tool, which includes parameters like BMI, unplanned weight loss, and acute surgical illness. Based on this, patients are categorized into low risk, moderate risk, and high risk. High risk patients require nutrition support preoperatively and reconsider the optimal surgical time. If required, we can postpone the surgery and improve the nutrition. The other index used is prognostic nutritional index, which considers parameters like serum albumin level and total lymphocyte count. And the next one is controlling nutritional status index. This includes parameters like serum albumin level, total lymphocyte count, and serum cholesterol level. So CONUT score of more than 4 shows that patient is undernourished and they have high risk of postoperative complications. So nutrition management is by oral nutrition, high protein and high energy supplements, immunonutrients like glutamine, arginine, omega-3 fatty acids, and enteral and parenteral nutrition. Anemia is not just a lab value, it should be considered as a disease and treated accordingly. Identify the cause for anemia and treat it with iron supplements, folic acid and vitamin B12 supplementation, erythropoietin stimulating agents, or preoperative blood transfusion. Functional status assessment is mainly done to assess the functional capacity. Functional capacity is the maximum physical capacity that an individual is capable of performing and serves as a valuable measure of the body to effectively respond to physiological stress. It is like juggling between multiple jobs. So how do we screen functional status of the patient? By 6-minute walk test, assessing the body mass index, weight loss, and emotional factors like anxiety and depression. And then assess by cardiopulmonary exercise training, stair climb test, body composition, 3-day dietary intake, and emotional factors. Intervention to improve the functional status is by aerobic exercise, resistance exercise, flexibility exercise, nutrient-based interventions, and cognitive behavioral therapy. The most common index which can be used to assess functional status assessment is metabolic equivalence. All of us know that the metabolic equivalence of less than 4 is considered as poor, and such patients have high postoperative complications. Eastern Cooperative Oncology groups came out with an ECOG score, which considers performance capacity of the patient and the ambulatory level of the patient preoperatively, and that how it affects the postoperative morbidity. These are all the subjective indexes which I told now. Now coming to the dynamic index of functional status assessment. It is CPET, that is cardiopulmonary exercise training. It's a dynamic, non-invasive assessment of cardiopulmonary system at rest and during exercise to determine the functional capacity. It has two components, static cycle and metabolic cart. Patient will be in static cycle on bicycle ergometer, and patient will be connected to the monitors, which will be relayed on the metabolic cart, and we will have a continuous reading of ECG, breath analyzer, and NIBP readings. So CPET basically uses the concept of anaerobic metabolism, which happens when there is vigorous exercise. So how do we interpret it? First, we need to identify if the test was done for the maximal. That is, was respiratory exchange ratio of less than 1.1 was there, heart rate of more than 90% predicted max, patient exhaustion. If the test was not maximally achieved, or why was the test stopped? What was the exercise limitation? Assess for the cardiovascular. Is it because of cardiovascular, which shows that it could be because of cardiac disturbances? Is it because of pulmonary, which shows that it could be because of a pulmonary disability or a disease? Or it could be because of other factors like leg or back pain, and if the patient is not exhausted, cardiovascular concern. So the inability to complete the test due to poor mobility, physiological reserve, or inability to follow instructions is associated with increased risk of postoperative morbidity and mortality. Anaerobic threshold of less than 11 ml oxygen per kg shows that such patients are high risk for surgery. Frailty. Recently, frailty is one of the components which is newly added to assess the functional status. So frail patients they have 5 times more risk of morbidity and mortality. Frailty can be assessed by frailty index, Edmonton Frail Scale, modified frailty index. So when I Googled, I found few articles which told that frailty predicts postoperative complications in major surgeries. Then exercise prehabilitation. Cancer and chemotherapy results in skeletal muscle wasting and cachexia. 2 to 4 weeks of isometric muscle training, gait training, core muscle training, and inspiratory muscle training is recommended. If the patient has undergone neoadjuvant therapy, 2 to 6 months is recommended. So exercise prehabilitation is indicated for better postoperative recovery and functional status recovery. So there are many articles which suggest that yes, exercise prehabilitation in cancer patients is found to be safe and effective and definitely will help in improving postoperative functional capacity. Optimization of comorbidities. Smoking. Patient could be a chronic smoker. So chronic smoking can cause elevated blood carbon monoxide levels that can result in 3 to 12% reduction of oxygen availability. Nicotine stimulates a surgical stress response with increase in heart rate, arterial blood pressure, and peripheral vascular resistance. So encourage cessation of cigarette smoking for at least 8 weeks, limit the duration of surgery to less than 3 hours, use laparoscopic procedures, use good analgesia, multimodal analgesia, chest physiotherapy, and continuous positive airway pressures. Diabetic management, other comorbidities are diabetic management, reduced alcohol intake, coagulopathy management, and antithrombotic prophylaxis according to the ASRA guidelines. ERAS. It's a multimodal pathways designed to optimize perioperative care to minimize surgical stress and accelerate recovery in cancer patients, leading to shorter hospital stays and potentially improved outcomes. It consists of preoperative optimization, intraoperative optimization, postoperative care, and benefits of ERAs are shorter hospital stay, on-time initiation and completion of chemotherapy, reduced complications, and improved recovery and cost savings. Perioperative pain management. Coming to pain management need not be only post-surgery or during surgery. It should be initiated since the time the patient complains of pain. It could be because of cancer itself or post-surgery or palliative. It is best done in collaboration with acute pain services in the hospital. Challenges faced in pain management in cancer patients are, it could be because of cancer-related pain itself, opioid tolerance, and complications because of pain medications or cancer. Pain can cause stress, anxiety, and depression. So, why pain management is required preoperatively? Because to reduce the stress, anxiety, and depression. And also, adequate pain management helps in good physical therapy and rehabilitation. That's why preoperatively, pain management of pain modalities available is to be discussed with the patient and it should be individualized. We have multimodal approach with both pharmacological and non-pharmacological methods. Various cancer pains are neuropathic pain, acute pain, chronic pain, breakthrough pain. I'm not going into details of this. So this is the multimodal analgesia for pain management. Then psychological support. Cancer patients often suffer from anxiety, depression, and low self-efficacy. Education programs to reduce anxiety and improve patients' anxiety should be incorporated. Timing of surgery. It is generally advised that time to surgery after neoadjuvant therapy should be several weeks to allow a reasonable recovery from cytotoxic adverse effects and a reduction in disease volume. A TTS of 4 to 6 weeks is often considered the optimal interval. Chemotherapy, immunotherapy, and radiotherapy effects. So affects both innate and adaptive immune system. Stimulatory to immunosuppressive effects. Myelosuppression can cause neutropenia, which has to be treated by irradiated transfusion, myeloid growth factors. And pancytopenia can cause hemorrhage, reduction in oxygen carrying capacity. Procoagulant, antifibrinolytic, and pro-aggregative response can cause venous thrombosis, so adequate thromboprophylaxis should be considered. Effects of immunotherapeutic agents on various organ systems. On CVS, it can cause myocarditis, pericarditis, cardiac fibrosis, arrhythmias, heart failure, and pericardial effusion. On respiratory system, pneumonitis. Endocrines, there could be hypophysitis, hypothyroidism, hyperthyroidism, primary adrenal insufficiency, and insulin-dependent diabetes mellitus. Hepatotoxicity and generalized symptoms like fever, fatigue, diarrhea, nausea, anorexia, neuropsychiatric disorders, thrombocytopenia, and leukopenia. Effects of chemotherapeutic agents. Apart from their cytotoxic effects on malignant cells, they also have toxic effect on normal body cells, which are responsible for the side effects. So like alkylating agents can affect all the systems like cardiac, respi, hepatic, and generalized. Anthracyclines are majorly affects cardiac. They are cardiotoxic. Pyridine antagonists again affects all the system with bone marrow suppression and thrombosis. Arsenic trioxide, cardiovascular and hepatic mainly. Cytotoxic antibiotics like bleomycin causes lung fibrosis. Platinum compounds, cardiac and hepatic, and also peripheral neuropathies. Topoisomerase antagonists causes hepatic toxicity and generalized symptoms. Cholinergic syndrome is usually associated. Vinca alkalides has hepatotoxicities and peripheral neuropathy and bone marrow suppression. Radiotherapy. Radiation toxicity affects various organ systems, including the immune system. Radiation doses of 5 to 10 gyrates have very minimal side effects. Vascular endothelium gets affected with doses of more than 10 gyrates. And lung parenchyma is affected with doses of more than 20 gyrates. Radiotherapy effects on different systems. Cardiovascular, it can cause pericarditis, arrhythmias, pericardial effusion, QT prolongation, and coronary artery diseases. respiratory, pulmonary edema and pneumonitis, and lung fibrosis, and others hypothyroidism. On head and neck, radiotherapy effects on head and neck. It can cause necrosis, mucositis, fibrosis, glossitis, increased mobility or restricting mobility, osteonecrosis, pathological fracture, edema of glottis and epiglottis. So what could be our anesthetic implications? Difficult mask holding, airway bleed, restricted mouth opening, restricted mobility and difficulty maneuvering laryngoscope blade, poor visualization of glottic opening. So this is one of our patient who has a limited mouth opening post radiotherapy and cancer complications. It's a skin involvement and ulceration. The other next important thing is local effects of tumor. It could be because of the location of tumor extent, metastatic spread, and extravascular fluid accumulation. Local effects of tumor can cause compression, mechanical obstruction if there's a huge thyroid mass like shown, tissue destruction in oral cases depicted here, ulceration and hemorrhage. Mediastinal mass can have tracheobronchial compression, great vessels compression, and cardiovascular compromise. All this needs to be elicited during history and examination phase. And extent of the tumor. In this, we need to counsel the patient preoperatively about their positioning of the patient, difficulty in positioning the patient, mask ventilating, or securing an airway. The other next one is huge intra-abdominal mass, which can cause various hemodynamic disturbances because of its decreased venous return, proximity to major vessels. They can have symptoms because of reduced gastric emptying and diaphragmatic splinting. So evaluate preoperatively. Risk assessment in oncological surgeries. Usual cardiovascular risk assessment by ACC/AHA guidelines and Lee's cardiac risk index. Pulmonary risk assessment along with pulmonary function test. And surgical risk assessment is done by POSSUM score, that is physiological and operative severity score, which includes physiological parameters and operative parameters. Based on this, patients can be categorized into minor, moderate, major, and major plus. Next one is a surgical outcome risk tool, which considers only surgical parameters, like what group patient belongs to, what is the surgical procedure, whether it's a minor, major, or complex surgeries, whether it's elective or emergency, cancer, and age. The other commonly used is ACS-NS-QUIP. In this, both patients' demographical parameters, comorbidities, and also surgical complications or procedures is taken into consideration and assessed. So considering all this risk assessment, rehabilitation, effects of chemotherapy, radiotherapy, and everything, whatever was dealt till now, what are the investigations that has to be done? Considering the cardiac system, ideally we need to have a 12-lead ECG, QT interval analysis, echo, troponin levels, and NT-proBNP levels. Pulmonary saturations preoperatively, chest X-ray, PF pulmonary function tests, and CT scans. Liver function test, renal function test, and coming to endocrinology, thyroid profile, ACTH, cortisol, electrolytes, because patient can be on steroids and can have Cushing's and all. Head and neck mainly airway management and planning. Assess the airway, discuss with the surgeon, discuss with the patient, prepare the patient for difficult airway and its complications. And albumin and thrombosis risk evaluation should be done preoperatively. So anesthesia for patients with cancer pose significant challenges due to physiological derangements because of multifactorial causes. Optimization of systemic illness is challenging. A thorough preoperative assessment with correction of nutritional status and electrolyte abnormalities, careful intraoperative planning and monitoring, and intensive postoperative monitoring is essential for positive outcome of the patient. Anesthesia and recovery of these cancer patients should be planned in accordance with the surgical team as a teamwork. Counseling in cancer patients is important. Thank you. Hope all of you are ready to induce onco patients now. Thank you.